Democratic Republic of Congo. This is the plan of our presentation. Inherited retinal diseases are a heterogeneous group of disorders that cause incurable visual loss, mainly due to the dysfunctions or degenerations of rod and cone photoreceptor cells in the retina. Dozens of different diseases are included, with wide and sometimes overlapping spectrum of phenotypes. The age of onset of RAD is highly variable, ranging from childhood to mid-adulthood. An early clinical feature of RAD is night blindness, often starting in adolescence, followed by progressive loss of peripheral visions, and in many cases culminating in the loss of central visions and complete blindness in midlife. Ophthalmologic hallmarks of the disease include an abnormal fundus with bone spicule pigment deposits, attenuated retinal vessels, chorioretinal atrophy, and a waxy optic disc pallor. Electroretinography often reveals severely reduced or non-detectable responses. Patients can also present reduced visual fields. RAD can be subdivided in two types: non-syndromic RAD without systemic abnormality, syndromic RAD, where retinal degeneration is associated with other symptoms due to systemic diseases. There are two most frequent pathologies: the Usher syndrome, characterized by early onset of congenital neurosensory hearing impairment, followed by the development of RAD, and the Bardet-Biedl syndrome, characterized by RAD, polydactyly, obesity, renal abnormalities, hypogenitalis, and mental retardation. Many other complexes and pleiotropic conditions include RAD as a component. The inheritance patterns of RAD can be classified as autosomal dominant, autosomal recessive, X-linked, dygenic, and mitochondrial. The autosomal dominant form concerns 30 to 40% of cases. Autosomal recessive is about 50 to 60% of cases, and the X-linked form concerns 5 to 15% of patients, and is the most severe subtype of the disease. Rare cases of RAD presenting mitochondrial or dygenic inheritance or uniparental disomy have also been described. A number of cases cannot be classified due to the lack of family information and are simply referred to as simplex. Overall, more than 200 genes are associated with RAD. The non-syndromic form, mutation in more than 15 genes, are known to cause the disease, and nearly 3,100 mutations have been reported in these genes. Mutation in 12 genes cause Usher syndrome, and in 16 genes are associated with Bardet-Biedl syndrome. Together, these two diseases account for 1,200 pathogenic mutations. The relative frequencies of the different genetic forms of RAD vary in different populations throughout the world. In Africa, there were some studies carried out in Nigeria, South Africa, Egypt, Algeria, and Tunisia. No study is available in Central Africa, and very little information exists on the phenotype and genotype of RAD in Central Africa. The purpose of our study was to identify the genes and mutations responsible for the RAD in the Congolese population. The study was carried out in Kinshasa, the capital of DRC, in two hospitals, in the Teaching Hospital of Kinshasa and the St. Joseph Hospital. Inclusion criteria of our patients were a clinical diagnosis of RAD and to agree to participate in the study. We included 7 indexes from 7 families. Each patient underwent a standard clinical examination with a dysmorphism evaluation and a complex ophthalmologic assessment. A venous blood samples was taken for all the patients. The DNA samples were extracted in the Center for Human Genetics of the University of Kinshasa. Then the samples were sent in USA, where the clinical whole genome sequencing were performed in the Clinical Services Laboratory of the Illumina through the Illumina High-Hope program. Our series included 4 men and 3 women. The age of our patients ranged between 27 to 77-year-olds. We have 2 familial cases and no dysmorphic cases. About ophthalmic finding, 5 patients complained of decrease of visual acuity, and 3 of them had hemerolopia. In fundus examination, bone speckles were found in all the patients. 3 patients had a thinning of retinal vessels, and 2 of them had a retinal pigmented epithelium atrophy. In the first family, we have sporadic cases, and the clinical whole genome sequencing did not allow us to identify a causal variant for the IRD phenotype. Genomic data will be reanalyzed in 6 months' time, hoping to solve this case. In the second family, the mother and 3 daughters were affected. The clinical whole genome sequencing identified 2 novel mutations in the ADAM9 genes for the 3 girls, including a stop mutation marked with a red asterisk, classified as pathogenic, and a small intragenic deletions marked with a green asterisk, which is classified as likely pathogenic. Interestingly, the affected mother is heterozygote for the deletion only. In the absence of the father, we assumed compound heterozygotes for these 2 women and suspect that the affected mother could reflect a novel inheritance form of ADAM9 related cone rod dystrophy, similar to mixed inheritance observed in RP1 associated IRD. In family 3, in this woman, the clinical whole genome sequencing identified a novel stop mutation in the RP1 gene in heterozygous state. This mutation is classified as likely pathogenic. The other family members are reportedly unaffected and were not available for testing. We assumed causality of this variant and returned the diagnosis of retinitis pigmentosa type 1. In this man, the clinical whole genome sequencing identified 2 novel heterozygous variants in the MERTK genes and a missense variant. These variants are classified as a variant of uncertain significance and likely pathogenic respectively. The other family members are reportedly unaffected and were not available for testing. We assumed causality of this variant and returned the diagnosis of retinitis pigmentosa. In family 5, the clinical whole genome sequencing of this man identified 2 heterozygous variants in the CYP4V2 genes. Both are novel missense variants. These variants are both classified as variants of uncertain significance. The other family members are reportedly unaffected and were not available for testing. We are performing now the phenotype reserve to validate this diagnostic. In family 6, The mother and her first son are affected. Clinical whole genome sequencing identified a pair of variants involving the AfSHG gene and a 8 kilobit deletion of chromosome 1, which is not found in the proband's mother, and a stop-gained variant that is present in the mother. Both are de novo and are classified as pathogenic. Variants in AfSHG are associated with Usher syndrome type 2, which is consistent with the reported clinical phenotype. We assumed compound heterozygotes for this man, which is in consistence of a novel inheritance form of Usher syndrome. So, conversely, for the mother with carrier for the heterozygote SHA2, similar to mixed inheritance observed in RP1 associated IRD. In family 7, the clinical whole genome sequencing of this woman identified an homozygous missense variant in the HFT140 gene. This is classified as a variant of uncertain significance. We are performing now the phenotype results to validate the diagnostic. In conclusion, we report on the first cohort of African RD patients investigated by clinical whole genome sequencing. Our results indicate that the spectrum of RD causal genes is broad in Congolese patients. We have expanded the spectrum of causal variants for RD. These findings will be included in publications and deposited in ClinVar. We also raise questions on possible mixed inheritance for two RD genes previously constrained to autosomal recessive inheritance. This report demonstrates the power of clinical whole genome sequencing as a first-year test in individuals with a suspected genetic diseases in resource-limited African population, especially for genetically heterogeneous diseases where multiple cases of missing heredity have been reported. We are thankful to patients and their family for consenting for the clinical whole genome sequencing and giving the authorization to use the image. We thank the Illumina IOP program for donating the clinical whole genome sequencing and to the Illumina Clinical Lab for the analysis. Thank you to my supervisor, Professor Emelu Maka and Jehimupungu, and to my colleagues. Thank you for your attention.